It's a little bit controversial. I think what's not controversial, as we've both said, is that lifestyle has a huge impact on cancer prevention and your risk of recurrence. And I think all the medical societies and the cancer societies worldwide agree with that. And obviously that includes nutrition. But what is more controversial is the metabolic theory of cancer progression and initiation. And the idea that you can use nutrition to treat cancer. So I just want to show you a video to set the scene.
Okay.
And then you can tell me what you think.
A solution to the cancer problem, to manage cancer without toxicity, is to simultaneously restrict the two fuels, glucose, which is already in our bloodstream from the food we eat, and the amino acid glutamine. If we stopped eating and we took a low carbohydrate diet and just did water-only fasting, we would get into nutritional ketosis. The tumor cells have a bad mitochondria. They're dependent on glucose and glutamine. We can replace glucose and glutamine with ketone bodies. So we selectively marginalize these tumor cells slowly over time. They slowly start to die, the blood vessels disappear, and the body comes in and dissolves them.
That was Thomas Seyfried, and he is getting lots of traction. He really believes in this theory, and obviously it's incredibly interesting from a research point of view. What do you think?
It's interesting you say he's getting a lot of traction because he's been doing that for 25 years.
Mm-hmm.
So, and I think he had a lot of traction before, and he still has traction, and it can be amplified on social or other places. I am a believer with caveats. I'm fully on board. One thing about my training, I actually dropped out of medicine at one point. I like to say dropped out, but I got a fellowship and left medical school and went to a place called Rockefeller University.
That is definitely not dropping out.
Yeah, no. But it sounds so much better when you leave medical school to move to New York and study nutrition, which, as the cliches always go, doctors get an hour of nutrition in their medical school training, maybe a day out of the 4 years. And I spent a year studying nutrition, which really means energy metabolism and human behavior. And that was the name of the laboratory at Rockefeller University. And I worked on neuropeptides involved in feeding hunger and satiety. One of my colleagues was studying fat cells. We were, it was the early 90s, and something called chromosome walking. We didn't have next-gen sequencing, but we were working with these obese laboratory rats.
Right.
And we would be able to predict which of the newborn pups would become obese. And we even had human patients, real people, coming in, spending a month at a time with us, where we would flip a coin and reduce their caloric intake by 10 or 15% in a controlled environment.
Yeah.
So this whole panoply of studies on nutrition, it's been critical, which is why I know about Tom, and it's been important in every aspect of medical care that I've been involved with through the rest of my clinical career, because what we eat really matters. And the carbohydrate metabolism of cancer cells can be manipulated.
Okay.
Now, this is where depends comes in, because that doesn't mean it can be cured. I think that the metabolic theory of cancer is incredibly valuable in a rare tumor, which doctors know, glioblastoma multiforme. So horrible brain tumors really respond well, especially pediatric brain tumors respond really well to a keto diet along with other metabolic interventions. To go back on Tom and metabolic theory, you have to, if you rewind the history, the biggest punctuation mark you'll hit first is the Atkins diet. And Atkins gets a bad rap because he was a great marketeer and had built a great business. But the low carb aspect of Atkins was the same thing that Tom's talking about. But what Atkins was doing was only rediscovering what the French had been doing and what Johns Hopkins had been doing 100+ years ago. The keto diet was first formulated prescriptively at Johns Hopkins for pediatric seizure disorders. And so again, through manipulating the mitochondria, the glucose metabolism and energy metabolism, that is a really successful treatment for select seizure disorders in adults and children. Now, what does that mean today in breast cancer? The low carb diet is important, or maybe it's better to say that a highly processed diet is unhelpful. And low carb diet is also a funny term because I can get fairly pedantic and prescriptive myself. Somebody says they're doing keto, I'm going to ask them how much fat they eat, and they don't realize that the keto diet is actually 70% energy from fat. That's 1,400 calories a day on an average American male. That's a lot of coconut oil, which we don't always recommend.
Yeah.
And someone thinks if they eat a porterhouse steak that it's a fatty product. Well, it's mostly protein with some fat in it. And so people aren't really doing keto diets, and your low carb and my low carb may be different.
Right.
But I think getting rid of the processed food and the ultra processed food is really the issue.
Okay. So you feel that it is definitely important, that metabolism is incredibly important in the initiation of cancer and the progression. But you're not necessarily recommending the ketogenic diet to all your patients, or are you?
I am not recommending the keto diet to my patients at this time. I would say that our practice was the place in Singapore for a very long time to get the supervised ketogenic diet. I have 2 or 3 nutritionists. We have a nutrition coach. We have counselors. This integrative approach, multi-specialty approach to cancer care, to screening, prevention, treatment, and survivorship has been, the passion project we've built over the last 15 years. And so I had one of my dietitians who's a vegetarian. I credit her with being open to the keto diet and prescribing it to our cancer patients. First caveat, we're talking about stage 1, 2, 3.
Okay. That's important.
Patients we're treating with curative intent.
Yeah.
Second, she gave me the phrase that what we offer is culturally appropriate nutritional support.
Okay.
I really like that. I don't recommend a diet to someone. There's no one size fits all. When the patients come to me and say, can I do this? Can I do that? How does it fit into their lifestyle? Is it sustainable? And we did use the keto diet a lot. It was a great and is a great weight loss tool. It's an intervention. I don't think it's a lifestyle for the vast majority. It's not sustainable. And it may be fairly unhealthy in the long run.
That's what I was going to ask you about.
It depends how you do it. There's clean keto. There's dirty keto. The issue is, why are you doing it? Are you doing it for weight loss? Okay, we can do that for 6 months. We can use it to go from one state to a better state, but maybe there's a maintenance diet that's better.
Absolutely.
Now, we really don't do that much keto work anymore because Ozempic and Mounjaro, semaglutide, tirzepatide, all of these drugs have completely changed the game.
Right. Okay.
They have completely changed the game in helping us restore metabolic health.
Okay. I want to get back into that. I suppose I just wanted to go back. So the reason why I said Thomas Seyfried's theories are gaining traction, it wasn't necessarily gaining traction in the medical field. Obviously, he has been going for a very long time, and he very much believes in this and has built his career on it. It was more that it's gaining traction within patients in the general population, who may not necessarily understand all of the kind of the nuances of what he's saying. And I suppose we as doctors, whenever we're talking, to the public, have a responsibility to make sure that we're saying the right thing with all the nuances, and we're not misleading people. Because I think just seeing on social media the following that he's got, and that others like saying the same thing like him that have got. And then on the other side, you see cases where people are dying from their cancer because they're going down the alternative route. We need to make sure that we're really balanced in our messaging. So just in terms of if you've got if someone's listening to this and they've got cancer, just explain what you're saying in terms of whether you think it will help, whether you think it will cure them, and if this is something they should be exploring on their own.
So first, I think the high level is nutritional interventions are not curative interventions.
Okay.
So I would not abandon conventional therapy for any form of nutritional therapy. And I would also point out, even within our medical specialties, we wouldn't abandon radiation for medication. We have to work in partnership with the tools available. And in this case, we do not want to abandon drugs, radiation, surgery for just nutrition alone. Nutrition is incredibly important at all phases, the prevention, the treatment, the survivorship.
Yeah.
How we do it and how it gets integrated and when it gets integrated becomes an important topic. I'll give you an example, and I don't know if you were going to go here, but we do recommend fasting. So I'm a big advocate for fasting and what's called a fasting mimicking diet during chemotherapy for patients who are undergoing treatment, which achieves similar goals to the keto diet. Because whether it's keto or low carb or fasting, what we're really talking about first is the elimination of the sugars and understanding that cancer cells are glucose dependent initially. If they were always glucose dependent, maybe you could talk about keto being curative, but there is no way to rid our bodies of glucose. And the body will also use glutamine. And we definitely have experimental drugs that block glutamine, but they kill patients too.
Oh,
So they're toxic. So
Okay.
we really need our glutamine to some degree. Now, how does fasting work? And this is where metabolic theory gets applied. And the person who gets the most credit here is Dr. Walter Longo, who's also in the world is adopting his views as well. Here's the catch. So the cancer cells are addicted to glucose. And when we fast, our body's metabolic rate slows down. But cancer cells being mutated ignore the signal. Okay, the example that's often given is if it's raining outside, you open your umbrella. You got the signal.
Yeah.
Cancer cells ignore the signal. So now these cancer cells, which are hypermetabolic and ignore the signal that the body is fasting, they keep demanding whatever glucose is left over. And you go from a blood glucose of 100 down to a blood glucose of 70, and you might feel a little lightheaded. Maybe you feel comfortable, uncomfortable. But those cells are, I call them wobbly. So now they're like, where's my next meal? Where's my next meal? And they're a little unstable. At the same time, our healthy cells, the stem cells in our bone marrow, the stem cells lining our gut, the cells protecting our hair follicles, all slow down. Now, chemotherapy works by incorporating itself into cells that are rapidly dividing. So we just laid out a scenario where the cancer cells are still going full speed, but the rest of the body slowed down. So you get this double benefit where fasting for 24 hours before and after chemo causes less toxicity on healthy cells and theoretically gets a better outcome in killing cancer cells. And this has been shown in randomized clinical trial data. Not the best and most robust data in the world, but it's decent data, particularly in preoperative women with breast cancer who are undergoing preoperative chemotherapy. Women who can stick to the fasting protocol are 4 times more likely to have their cancer completely disappear, going onto that higher curve that we talked about, whereas women who can't perform the fasting, can't get through it for one reason or another, which is often just the lack of support on the medical system, the knowledge and access. But if you don't achieve it, then they are almost never going to get a pathologic complete remission.
And why is this not part of standard protocols then?
I don't think it's crossed the evidence-based medicine threshold at the randomized phase 3 level, and it's very hard to achieve those studies. I point out it's stage 1, 2, 3, and its safety. I mean, there are a lot of studies that show the safety of this fasting protocol around chemotherapy. It reduces the toxicity. It might enhance the benefits. It certainly has suggestive benefits in these early randomized phase 2 studies and smaller studies, but again, not the gold standard double-blind randomized New England Journal study. But there's not really a great harm here. When performed with the right education, setting, and support, it's quite doable. But do all the medical teams, all the oncology practices, do they have the resources?
The content of this podcast is for educational purposes only. It is not intended to replace the doctor-patient relationship, nor does it constitute personalised medical advice. If you are affected by any of the topics discussed, please speak to your doctor or a qualified healthcare professional.